Welcome, everyone. I hope you've enjoyed a quick bit of refreshment before we move on. So welcome back. We're going to have the second half of our program this morning. As you can see here, we've got our DSRHP colleagues ready to share their success stories with us. So they're going to be seated here. But before we do that, we have one more speaker. And I know that many of us are wondering, as Senator Watson referred to, the future is scary. And we want to know what's going to happen with the 1115 waiver coming forward. And there's still a lot of questions, and we still won't know for a while. But we have a speaker here whom I know many of you are familiar with, is Lisa Kirsch. She is the Chief Deputy Medicaid CHIP Director for Policy and the Healthcare Transformation Waiver at Texas Health and Human Services Commission, the state Medicaid agency. And I know you all know that Lisa and her team have really worked tirelessly to implement this waiver, and she is moving forward and working with the Center for Medicare and Medicaid Services to negotiate the terms of an extension for the waiver. So Lisa's here to share information on that today. Please welcome Lisa Kirsch.
Good morning. I'm really happy to be here today. We got a chance to see many of you last week at our statewide event, but because we have so many providers across the state, we can't have everybody attend that event. So fortunate to live in Austin and to be able to join you for this one as well. These are similar to some of the slides I spoke from last week, so I'm not gonna belabor some of this, but I will go through at a high level where we are on the extension. And I remain very optimistic, as we always do, and we don't want you to be worried about the continuation of the work that you're doing, although we definitely have some negotiations ahead of us with CMS. But with all of that said, they and we know how important what you're doing is to low-income Texans and to the Texas delivery system in general, and so I'm confident that I will reach an agreement that will allow your good work to continue. At a very high level, this waiver has several major components. It includes our big Medicaid managed care programs. It includes an uncompensated care pool for hospitals and other providers, and of course it includes the DSRHP pool. This month, we will be submitting to our federal partners the request to extend the waiver, to extend all three components of the waiver, really acknowledging that we think we've made good progress related to all of our initial waiver goals. We want to further strengthen what we're doing, but we really need more time. So specifically, we are asking to continue DSRHP through an extension period, and the initial ask is for 5 years. We will see how that goes. It may very well be that we end up with initially a shorter extension period than that, to continue the DSRHP pool at $3.1 billion per year. And then we're going to be asking for an uncompensated care pool that's equal to the unmet UC need in Texas, which continues to grow. So we know that our hospitals and other providers that serve Medicaid and the indigent are continuing to see their costs for serving them not be able to be met with the funding sources that we have. We did want to mention, and this is going to be a piece that will come together in the next year, CMS is going to be asking that HHSC submit a report to them that describes how these two pools tie into our overall Medicaid financing. We know that request is coming. We haven't gotten it yet. But when they do, we'll be working to get them some data that talks about how the UC pool and how the DSRHP pool fit into Medicaid financing in Texas. We do anticipate negotiations with CMS. This is complicated. It will not happen quickly. One of the things that even after last week, and we did have a CMS representative here, and I was really glad that he got to see some of the good work going on in Austin. I think that's super important, and I also like to see the good work going on here. That more and more we're thinking about a transition period. So one of the things that my team will be doing for DSRHP is just kind of knowing that nothing between the state and CMS gets the details. It takes a while to hammer them out. Looking to probably a 1-year transition period for DSRHP, where we may be doing something very similar to what we're doing now as we work to think about what does the next phase look like. So we got a lot of comments from you all and folks around the state about the draft extension request, and we've moved that draft packet onto the governor's office, and we'll be working with them in September to submit it. We didn't substantially change the extension request based on the public comment, but did want to acknowledge all those comments got folded into the packet that we're submitting. And some of the major themes were folks wanted to support increased collaboration with community physicians, with FQHCs, HIEs, cross-regional collaboration. Definitely a request for additional targeted projects, including related to pediatrics, behavioral health, and our rural regions. Of course, always comments about how we might want to change how the funds are allocated between different types of providers. That would be expected. And then lastly, we did get a lot of comments in support of a coverage expansion in Texas. And really where HHSC is on that, we acknowledge the comments. You know, our state leadership has directed us at this time not to expand Medicaid coverage, and so that will not be included in this extension request, but just wanted to acknowledge that a lot of folks did ask about that as well. In terms of our principles for DSRIP, and you all have heard this before, we want to further strengthen our healthcare systems. We recognize the need to maintain program flexibility due to the diversity of DSRIP providers. We need to think about ways to integrate with Medicaid managed care to the extent that we can, knowing that DSRIP also serves a lot of non-Medicaid patients. So we will balance that. We want to streamline, and I know you think that's funny, but we do want to streamline to hopefully make reporting and program administration easier both for the providers and for my staff. It's overwhelming right now, we know that. We're working with a group of clinical champions, some of them are here, that we want to help to identify best practices in DSRIP so that we can work to disseminate what are the best practices and replicate and build some of that into our regular Medicaid business as well. So we're really excited about that. And of course, and I think CMS saw this when Tim Hill was here last week, this program does a ton to support the healthcare safety net across Texas and is really, really important for that if we did not have this program, people would not get the same level of care and they would not get the same quality of care. Wanted to mention some themes from our federal partners just for an awareness for you as we go forward, where we know they're coming from as we negotiate with them. So you all heard this if you were there, DSRIP is a substantial federal investment. So CMS wants us to demonstrate the value of that investment. And one of the really big challenges for us has been because we have 1,450 DSRIP projects, and 300 outcomes and all the variety that we have, it's hard to take all of that and tell a story. So we're going to be working to do that better with you. We, of course, and they talk about this, they want systems of care. They don't want to be giving funds to individual providers and us not working to create systems with that funding. So we want to keep building that. Outcomes measurement is very important to CMS, including shared outcomes. And so we talked at our summit about some kind of a regional bonus pool that we might be looking at for the extension period where Region 7 as a whole, a small portion of your funds would be based on regional performance on some key measures. We know CMS wants that, and so we want to work with you on that because especially because of our mix of Medicaid and low-income uninsured. We don't have a lot of data on the low-income uninsured at HHSC, but we know that's an important population being served by the waiver, so we're going to have to work with our providers and our partners on this on how we can best come up with those measures. And sustainability. You know, CMS does not want DSRIP to be a never-ending supplemental funding stream. The idea is you take these funds, you learn, you improve your systems, you build that into how you do business in Medicaid. Texas is in a challenging position because we have a lot of folks being served by these funds who are not in Medicaid because we haven't expanded, but we still want to be thinking about sustainability to the extent that we can and working with you on that. We included these two slides at the summit, and I think they scared some people, so this is not to cause alarm at all, but we did want to share, again, this is a recent federal report that talks about some of the recently approved waivers and kind of some of the themes that we're seeing in them in terms of what CMS has been approving. They have been, like New York was the latest example, you know, more standardized waivers, increased accountability, more narrowly defined project menus, larger proportions of funding dedicated towards reporting and results, different ways of doing evaluation, Some of the things that we have now that we're going to ask to keep, they haven't allowed in recent waivers, so we're not sure which way they'll go on that. We have some partial payment, for example, for Category 3. They're narrowing that a little bit in New York. Not allowing carry forward. So instead they have these high performance funds. So these are all going to be things that we are going to advocate to continue. We just are not sure where it will fall out. There has been some information about project budgets and how funds are being spent. We saw in New York where as part of the valuation, they're assigning low-income patients to specific networks or participating providers to help allocate funds. And then again, emphasizing the importance of sustainability. So these are just all things we're seeing at the federal level. Remains to be seen how it will play out for Texas. But we just wanted folks to be aware of this big report that came out recently. Again, we think Texas is very different than New York. Just as our partners from California, California is very different from New York and very different from Texas. So, you know, I think CMS is seeing this is very difficult for them to administer with all the variation. So they're looking to see how can we make it more consistent. The states are looking to continue to say, we know it's difficult, but we are not New York or we are not California. So please let us continue to do something that works for Texas, and we'll definitely do that. I think they understand our argument that it took us a long time to get this program up and that we need more time to demonstrate outcomes. So that's one of our big arguments. The actual outcomes framework we have is exceedingly complicated. It took forever to negotiate even that framework with CMS. It's not a great fit for a lot of our projects, and we know that our providers are struggling with Category 3 outcomes and the technical complexity of it. I don't deal with that day to day, and I'm glad because it's very complex. But we need more time on the outcomes because we just think we have a very complicated technical framework now that may not be giving us all the information that we need. And you know, one of the very positive things about the interim waiver evaluation report, which will be about 600 pages and will be on our website soon, it really highlighted how the regional healthcare partnership structure has increased collaboration, and we think that's one of the very early positive results of the waiver is that people that weren't working together before as much now have a financial incentive really, as well as kind of a community framework to work together more. So we want to build on that, and we think that that's a strength of the Texas program and what you're doing here, you know, the learning collaborative activities at the regional level. So again, at a high level, we're going to ask to continue the existing program, the existing administrative structure, the role of the anchors. We believe the majority of the active district projects will be eligible to continue to give you more time to demonstrate outcomes. We are reviewing some projects now that are struggling or that we have concerns about, and just some in certain project areas too that we may ask to select to convert to something else. But at the end of the day, I think the majority of the work that's going on will be allowed to continue in the extension. And then again, we've talked about some of this already, aligning with Medicaid quality, managed care, looking at how DSRIP can inform Medicaid benefits. A couple of the early things we're seeing, both use of peer support specialists and community health workers, I think are a real strength of DSRIP. And Medicaid has struggled with adding those as providers, really because of the short-term fiscal implications to the budget. So, you know, anytime we add a new benefit, we have a pretty rigorous process to go through. But looking at what do we see from DSRIP that gives us the results of these types of things that we might make a stronger case for adding them as Medicaid benefits. I talked a little bit about these regional performance bonus pools. A lot more work to be done on that, but we wanted to let you know that our team is looking at that. And then other things we've thrown out that we think would be a benefit to CMS and would also strengthen the program. One is to collect Medicaid IDs from DSRIP to the extent that the Medicaid patients are being served. And we know some projects aren't serving many or any Medicaid patients, but to the extent that they are, if we have that data, we can then triangulate it with our own Medicaid data, and the state can really begin to analyze the results of some of these programs. So, we would like to be able to do that in the extension. We've talked also about requiring participation in ADT data exchange so that my understanding is this fairly basic piece of information about when a patient goes to the ED, is in the ED, hits the ED, is discharged or transferred. If we can get that information, get it to our Medicaid MCOs, get it to their providers, that's much more timely information than our providers have now about their patients going to the emergency department, which seems like a pretty basic thing that you would want a provider to know to coordinate care. So all of the details of DSRIP changes are going to be outlined in the protocols, and we're working on that now. We, again, with a heavy emphasis probably on that transitional year. So knowing that we may not be making any major changes in the very near future, but giving us time to plan with you on what changes might look like. I think the date for that webinar is looking like it might be the morning of September 29th. Not firm yet, but just FYI, that's probably when we'll do that protocol webinar. And we'll keep getting your feedback as we do that. You guys know our website, you know the email address if you need to contact us. But with that, I'm happy to answer any questions that you might have. And thank you again for all of your work. It's refreshing to get out of the office and actually see what's going on out here in Austin and the surrounding communities.
So questions, Sarah?
I have a question. Lisa, it's been so gratifying to be part of RHP7 and to see this collaboration that goes on and to be with all colleagues and peers. Has there been any talk about a state share to help finance some enhanced collaboration that could really provide for healthcare across county boundaries in a way that we're not able to now, given our funding constraints and our funding rules in Texas?
Could you repeat the specific question, a state share?
To help us in counties provide care across county boundaries to patients that we share based on just, normal commute patterns or access to healthcare patterns.
I want to make sure I understand your question. So funding?
It's hard for funding to follow the patient if you
Yes.
it gets care and traffic.
Sure.
Is there any way that the state can help us provide care for that patient irregardless of county boundary?
Sure, and I mean, this is this is the $10,000, well, not even 10,000, probably, $10 billion question is how we finance all of this. I mean, I think we have the relationship with the counties and where like certain communities have healthcare districts and are receiving patients from the outlying counties. A classic example I always think of is Dallas because, patients are coming in, but it happens everywhere we know. In terms of funding, we are on the Medicaid general revenue side, subject to our appropriations from the Texas legislature. I mean, I'm not aware of any major changes planned there. I think that what you see in the UC pool and what you see in the DSRIP pool, some of that is to indirectly help with that, but it's not as specific as what you've noted. So short answer is probably not, but certainly folks can always advocate for something like that. Kim. Hey.
Can you talk a little bit more about the regional bonus pool and specifically if any other states have adopted that or are in serious consideration? And then just a couple examples of metrics, at least at the HHSC level, y'all are thinking would be ideal for that type of a bonus pool if it were established.
Sure. So, yes, CMS has moved to this model of sort of shared performance. I think New Jersey was one of the first states that used that to try to basically, if funds hadn't gotten earned by an individual provider, they flowed back into a pool that they could use some of that leftover money to reward high performance. New York, extreme example in my mind, but I mean, the state of New York, if they don't, and I think their hospital admissions are high now, so I think they have a lot of room for improvement, but they have a goal in the waiver of a 25% reduction, I think, in preventable hospital admissions. And if the state does not achieve that as a whole, they will not be able to gain access to all of their funds. So that is an extreme example. We shared some data last week, and it's up on our website in one of the presentations. Dr. Betsy Shankman had a presentation the second day at lunch where we worked with her really on existing Medicaid measures. So this is data that we are already collecting for Medicaid. And we looked at all the measures we collect, and we looked at DSRIP, and we kind of tried to just throw out, these are some examples of measures on the Medicaid side that we think we could use. Some of them are the potentially preventable events, but there are many others that might be HEDIS measures or, follow-up care after a behavioral health care inpatient stay, asthma compliance. So are people hitting the ED for uncontrolled asthma? So we laid out HbA1c testing, which we don't even have access readily to the lab results for our Medicaid patients. So even like HbA1c control, if we wanted to use that, that would take extra cost for us to collect that data. So we were really trying to focus on what do we readily have available in Medicaid that it wouldn't cost us anything more. But we really need to carefully work with you on what is that overlap with DSRIP. And then the bigger question is on the non-Medicaid side. So DSRIP is benefiting a lot of folks other than Medicaid. And one data source we do have is the Department of State Health Services has hospital discharge data, and they're starting to get ED data that's all payer data. So if we can get that data, which is not as easy as you might think, even as they're a parent organization, if we can get that data, we could trend year over year, for example, ambulatory care sensitive ED visits, all payer by region. So we just kind of put some ideas out there initially. We are thinking there might be some state measures that every region would have as part of their bonus pool, but then we'd also give the region some flexibility within a list to pick from among some measures that they think best fits their district portfolio. So some combination of these three measures the whole state is doing, these three measures you got to pick as a region based on what you're emphasizing in district. It's very early, so that's why we need that transition year. We need to figure all this out, and it's going to take some time. Sure.
Other questions? Well, thank you, Lisa.